Good evening, everyone, and welcome to the first webinar in the European Academy of Pediatrics three-part obesity webinar series. My name is Artur Mazur, and I serve as a chair of the European Academy of Pediatrics Strategic Advisory Group of Adolescents. It is a great pleasure to see so many colleagues joining us today for this important discussion on the childhood obesity, one of the most significant public health challenges affecting children and adolescents across Europe and globally. This three-part webinar series is a true collaborative effort, and I would like to warmly thank our partner societies for their excellent cooperation and support in developing this series. There were the European Childhood Obesity Group, the European Confederation of Primary Care Pediatricians, and the European Pediatric Obesity Research Networks, EPROPS. Their expertise and engagement have been invaluable in the helping shape in a strong and practical program that reflects the realities on clinical care across Europe. Today's session focuses on childhood obesity in Europe, definition, determinants, and the health system responses, and we are honored to be joined by outstanding experts in this field. Before we begin, it's my great honor and pleasure to invite President of the European Academy of Pediatrics, Professor Bertolt Kolecko, to deliver the official welcome and opening remarks. Professor Kolecko, the floor is yours.
Dear Professor Mazur, dear Arthur, thank you very much indeed for your kind introducing words. And also, I must thank you for your central contributions to making this important webinar series get off the ground. Dear colleagues, dear friends, on behalf of the European Academy of Pediatrics, I would like to very warmly welcome you to this first webinar in our obesity series, consisting in total of 3 webinars, and we'll hear more about the other 2 at the end of this session. Clearly, childhood obesity is one of the defining health challenges of our time. Its impact extends far beyond physical health. It affects emotional well-being, long-term outcomes, and healthcare system across all the countries. As pediatricians, we are uniquely positioned to support prevention, early diagnosis, and effective management. And therefore, this webinar series aims to provide practical, evidence-based guidance and strengthening collaboration across primary care and specialist settings alike. We are especially pleased that this is the first of the 3 webinars dedicated to this topic, allowing us to explore the issue from multiple important perspectives. I would like to also sincerely thank our speakers for sharing their expertise with us today and during the next 2 webinars. And I also thank all of you who participate for joining and contributing to this discussion. So don't be shy, but prepare your questions and comments. We'll come back to them after today's 3 presentations, and hopefully we'll have enough time at the end to get to all your questions. So without further ado, let's get started. I would like to start with introducing our first speaker, Professor Wolfgang Ahrens. It's a great pleasure to welcome you. Wolfgang is a very distinguished researcher from the Leibniz Institute for Prevention Research and Epidemiology, called BIPS, in Bremen in Germany. He is certainly one of Europe's leading experts in epidemiology and prevention research. He's done extensive work focused on childhood obesity, prevention science, and population health across Europe, and he's been leading several European-wide research collaborations. So thank you very much for joining us. The floor is yours.
Yeah, thank you, Bertolt. I hope you can see my slide, at least my introductory slide.
Perfect, yes.
I really feel honored to be invited to give a talk in this conference here, in this webinar. And I try to give you at least a blink into what we have done in terms of research over the last decades. But of course, I will not be able to summarize all what we know and what we've learned over the last decades with regards to childhood obesity. Now I need to swap slides. This is my introduction. I will present two major components in my talk. The first one will be on global trends that have been assessed by the NCD Risk Factor Collaboration. Many of you may know it already or may have heard of this collaboration. They provide very informative descriptive data. And the second part will consist of some observations that we have made with our children cohort, a European-wide children cohort that we started to investigate in 2006 and that we are still doing research on until today and hopefully also in the future. Let me first introduce to you the NCD Risk Factor Collaboration. They collected data ranging from 1975 to 2016, so almost 40 years. And they included 2,416 population-based studies with measured height and weight in youth and adolescents, aged 5 years and older up to 19 years. They estimated trends over the whole period in 200 countries regarding BMI prevalence in children. And they used the WHO growth reference standards to classify weight status using the standard deviations, which is the Z-scores of BMI in children. And this is the main result of this endeavor, huge work. This is the number of girls on the left side and boys on the right side with obesity and how the numbers increased globally from 1975 to 2016. And what you can see here is that we are talking about a pandemic, not an epidemic, it's a pandemic of weight and obesity. And what you also see is the color codes. And since we are mostly interested in Europe, you may focus on the bottom part of this graph, where you see the bluish colors. High income English-speaking countries, which is mainly North America, and then the European countries, the other European countries, which seem to play a minor role in total numbers, but nevertheless you can see the increasing trend. But you also see that the trend is most prominent in Asia, in Asian countries, East and Central Asia. This is another way of looking at this pandemic. Again, the color codes, this relates to countries or to geographic regions in Europe. On the left-hand side, you see two graphs for girls. One describes the world mean and the mean BMI values in girls, 1975, and the bottom one in 2016. And you clearly see how the world mean, the global mean BMI in children 5 to 19 years is 17.2 in 75 and 18.6 in 2016, and even higher in boys. So you say the same relation, but you see that it's even higher in boys. And if you look at the color code, you can see that the bluish lines are always higher than the world mean. So that means Europe started already at a high prevalence level with a high mean BMI and retained this position, although globally all the countries increased with regards to child and adolescent BMI. Maybe it's easier to look at a map to get an impression of the distribution across the world. And this is shown here for girls in 2016, so the recent data. And you clearly see where the prevalence is highest. You see the US, you see the Arab region, you see the South or South America, and you see Southeast Europe as those countries where the prevalence in girls is highest. Overall, the prevalence in boys is even higher than in girls in 2016. The same countries emerge with maybe some additional countries like Australia, Brazil, or China, where they seem to catch up with this prevalence. A closer look at Europe and European regions is shown here. At the bottom, you see, for comparison purposes, on the left-hand side, the trends in girls, and on the right-hand side, the trends in boys. Dark red means a BMI above 2 standard deviations. Orange means a BMI between +1 up to 2 standard deviations of BMI. And the green area describes those who are considered as having a normal weight. So from -1 to +1 standard deviation. And you see that this green area becomes smaller and smaller over these 40-year periods. You see on the left-hand side on the top, boys and girls in high-income English-speaking countries. So that's virtually, as I said already, North America. And you see the increasing trend that seems to flatten a bit in these high-income countries. Not so much in the Eastern and Central European countries that are depicted on the right-hand side, but probably also in Western Europe. So the second and the third column on this picture. This can be better visualized on this graph. Again, the same countries, the same order. So on top, the females, on bottom, the males. Here, you also see a dotted line. So the full line means children, is the trend for children. The dotted line shows the corresponding trends in adults. So you see that the dotted line is always clearly above the one of children and adolescents. But you also see that more or less the trend in adults parallels the trend in children. In some areas, the trend in children seems to accelerate. Again, Central Europe, if you look at boys in Central Europe, while in Western Europe and in the US or North America, there indeed seems to be a plateauing after the year 2000 with regards to the mean BMI trend over this period. The conclusions that can be drawn from this descriptive statistics is that we do see rising trends, and we do see that they have plateaued in some of the high-income countries, but at high levels. The rising trends have accelerated in Asia, in many parts of Asia, and there these trends seem no longer to be correlated with those of adults. So they seem to accelerate in comparison to the trends in adults. While in Europe, we see a plateau in Western Europe in recent years. So something that's promising, but not making us completely happy because of the high levels in all. My second part deals with the Idefix family cohort that some of you may have heard of. So this is actually 2 studies that were linked and that were based on the same cohort that we established in the Idefix study. These are the countries that participated, and you may focus on the green ones. These are the countries where we collected data and examined children, ranging from the north in Sweden to south in Cyprus, from west in Spain to east in Hungary and Estonia. So not a full coverage of all European countries, but a good representation of the different lifestyles and climates and circumstances, living conditions. Later, at a later stage, Artur Mazur with his team joined in. So for the recent examinations that we did and data collections, we also have now data from Poland. This shows the time axis of the study, starting in 2006, 2007 with a baseline. At that time, we included more than 16,000 children who were 2 to 10 years old at that time. And 2 years later, we did a follow-up examination, still more than 13,000 children participating. Then we were lucky to get another EU grant, which we called iFamily, to do another follow-up 4 years later. Still almost 10,000 kids participated. And then we tried to get funding and tried and were not successful. And finally, we decided to perform at least a web-based follow-up. And still more than 5,000 children participated. And this time axis allows us to investigate, or allowed us, I must say, to investigate various transition periods from toddler to child, from child to an adolescent, and from adolescent to adult. Actually, we are preparing another follow-up, this time again with examinations that should start next year when they are all adults, when they are between their 20s and their 30s. A multitude of exposures was measured and a multitude of endpoints. So food choice, eating behavior, sensory taste preference, screen time, seems to get more and more important for child health, physical activity, mental well-being, family, social, and built environment, but also subclinical changes and health outcomes, not only body composition, but also many metabolic markers, and I will get back to those in a few minutes. These are the questionnaires. We did a 24-hour dietary recall, so a clear focus on nutrition in this studies. We measured physical activity with accelerometry. We were one of the first to have implemented accelerometry in large-scale population-based studies, and especially in smaller children. And we assessed the built environment in terms of how well is the living environment of children suitable for promoting physical activity in these children. We did anthropometry, we measured the bone health, the bone stiffness, and we collected blood, saliva, and urine. And then we had some specific tests in subgroups, up to functional magnetic resonance imaging and so on. I haven't mentioned that in the first round, we had an intervention component in that study with 6 key messages, and I present these to you. Gives you a first flavor of potential risk factors, because we used them also for the analysis when we did the observational study. So we had 2 messages on nutrition, a reduction of soft drinks, and increase of fruit and vegetable consumption. We had 2 messages for physical activity, reduction of screen time, and increase of daily physical activity. And we had 2 measures on stress. First one was the recommendation to spend more time with the family, and the second one was to take care that the child has an adequate sleep duration. So the results. Just some basic things that are well known and that we simply confirmed with our data. This is the baseline data set, 2 to 10 years at that time. And you see on the right-hand side, the orange means the children that are obese, the blue ones are overweight, and green means normal weight. And you clearly see that the ones with the highest prevalences of overweight obesities are in Southern Europe here, Italy, Cyprus, and Spain. And the ones with the lowest prevalences were Estonia, Sweden, and Belgium. This was also related to social position, as shown here. And especially in Germany, we had a high proportion of children coming from less educated families. And you see here the overall differences with Italy and Cyprus being on top, and Estonia and Belgium being at the bottom with the overall prevalence. But you can clearly see a trend from low over medium to high parental education, with the lowest prevalence in all the countries in children living in families with high levels of parental education. This is well known, and this is probably a good proxy for lots of behavioral and environmental risk factors that we need to consider when we talk about childhood obesity. We also defined or provided a definition for metabolic syndrome, because pediatricians were left alone with appropriate reference standards, often using then the reference standards for adults, like the ones that were promoted by the International Diabetes Federation. But these levels that are proposed there for adults are not suitable for children. So we derived a statistical definition of a metabolic syndrome, and you know what it includes. It includes blood pressure, lipids, waist circumference, and insulin resistance or diabetes, blood glucose levels or insulin levels. So we created a score, and this is depicted here in this graph. And this has been well received in the literature, actually, so that we currently have started to collect a bigger data set with even more studies to be included and to widen the age range up to adults, because here, due to the young age of the cohort, we were limited to younger children from 3 to 13 years, roughly. But you see that there is an age trend, both in different levels, both in boys and girls. And I present this because I will refer to this also in a minute. The interesting part of this cohort study comes when we consider longitudinal analysis. So descriptive things like the ones that I just showed to you are nice and informative, but not as informative when it comes to considerations that can guide us with regards to prevention efforts. And then it becomes much, much more valuable to consider longitudinal analysis of these data. We did a latent transition analysis with regards to the components of the metabolic syndrome, where we considered 4 of the metabolic syndrome components, which we classified in 3 levels. Normal means children with levels of these parameters that I just showed to you below the 90th percentile of the overall distribution. Then the second level was above the 90th percentile, and the third level was above the 95th percentile. These are cutoffs that are usually used to define elevated levels. Sometimes the 90th percentile is used to define an elevated level of a parameter. Other people sometimes use the 95th percentile to identify subjects that have elevated levels of whatever parameter you consider. And we estimated then transition probabilities over time. This is hard to understand, but I will explain it in a minute. Look at the graph. Wave 0 means baseline examination. Then we had another measurement 2 years later, which we called Wave 1, 2009 to 2010, when children were on average 6 to 11 years old. And then another 4-year follow-up in 2013, 2014, we call it Wave 2, with 10 to 15-year-old children. And now we looked at baseline levels of these metabolic parameters and whether they were below these cutoffs that I just defined, and how they developed during the follow-up, so over the 2-year period, for example. We included children that had provided at least 2 measurements of all the 4 components, so they had to provide blood. So we were restricted to those children that have provided blood. And we classified them and tried to group them into more or less homogeneous groups. And we identified 5. The first group means children whom we considered as metabolically healthy. The second group, children that we classified as being characterized by abdominal obesity. The next group characterized by elevated blood pressure. Then the fourth group characterized by dyslipidemia, which means triglycerides high, HDL cholesterol low. And then those who are suffering from several of the metabolic syndrome components. And this just shows within the groups that, for example, in the group with several metabolic syndrome components, 99.3% were estimated to have an elevated waist circumference. Whereas in metabolically healthy, we see that only 3.6% in this group appeared with an elevated waist circumference. Now, the interesting thing, when we look at the transition probabilities, then we see that those who were classified as metabolically healthy after follow-up, still 68.6% retained this healthy status. And few, 6.7%, were considered as developing abdominal obesity. So there is a small risk, like almost 7%, that between wave 0 and wave 1, they develop abdominal obesity, even though they were considered completely healthy at baseline. With regards to obesity, we see, unfortunately, that almost 80% retained their abdominal obesity. So once they had developed abdominal obesity, they retained it, and even worse, 18.5% developed further metabolic syndrome components, so elevated values for other metabolic syndrome components. And only 2.3% were estimated to become metabolically healthy over this period. And the worst description is seen here when we consider those who were already carrying several metabolic syndrome components at baseline. 99.8% retained those. So once they had developed a number of metabolic syndrome components, elevated levels for a number of these components, they had almost no chance to return to a healthy status, which means primary prevention is essential in these children. When we consider age groups, then you can see a dotted line, which is the reference line. So this is children who were metabolically healthy at baseline, and it shows the proportion of them who were considered as having an unfavorable metabolic profile at different ages. So with 6 years of age, 60%, 70% had still a healthy profile, while with 14 years, 60% only had a healthy profile. And this differed, and that's shown by the other lines, with lifestyle factors. And I explained to you the lifestyle factors at the very beginning that we were addressing. So we were benchmarking those lifestyle factors and asking, did they have an unfavorable lifestyle, which means did they meet or not meet the recommendations, spontaneously, the recommendations that we gave? And you see that an unfavorable lifestyle is associated with a stronger decrease, and especially if all factors were considered unfavorable, then a majority of children turned down to also an unfavorable metabolic profile. There is hope. There is hope, and this is depicted on this last or second last slide. Again, considering wave 0 to wave 1, so baseline to first follow-up, an observation period of only 2 years. It's not very long. And what you see here is the proportion of children who returned, of overweight children who returned to normal weight after 2 years. So children who were 2 to 3 years old at baseline, 50% of them returned to normal weight within 2 years, without any intervention. Without any intervention, spontaneous remission. Children who were 3 to 4 years old at baseline, still 1/4 of them returned to normal weight in this early age, in this young age. And you see there's a decline and then a leveling off. So from school age onwards, there's only, it remains at around 11%, 10 to 11%, the spontaneous remission rate. For me, this means that if we want to intervene, the age period that is most has most plasticity in terms of remission is this one. We just need to identify those who don't return to normal weight. What is the difference between those children who spontaneously return to a normal weight in comparison to those who don't? Because those may be the ones that we should target specifically for interventions. So, in conclusion, about 40% of children show metabolic.
You're muted now. Can you unmute yourself, please? Wolfgang, can you unmute yourself?
I don't know what happened. Actually, I didn't touch it. I didn't touch it. Okay, there's a strong age dependence. Go on. We see that dyslipidemia seems to be most reversible. We see that dyslipidemia or hypertension rarely occur in isolation, but more likely as a comorbid condition of abdominal obesity. Abdominal obesity seems to precede other metabolic disturbances, and almost no child that has several elevated metabolic syndrome components returns to metabolically healthy during 6 years of follow-up. Spontaneous remission is, of course, high in low children. That's maybe the promising thing, and that's why we think that need for early and multifactorial interventions is called for. Thank you.
Thank you very much for a very clear and most impressive presentation. And for everybody, don't be shy. Write down your questions and comments in the Q&A box so we can get back to them at the end of this webinar after the next two presentations. So let's go on and invite Professor Małgorzata Wójcik, who is from the Department of Pediatric and Adolescent Endocrinology at the Faculty of Medicine at the Jagiellonian University Medical College in the beautiful city of Krakow in Poland. She's a highly respected specialist in pediatric endocrinology. She has extensive experience in obesity, metabolic disorders, endocrine regulation, and adolescent health. Małgorzata's work focuses strongly on understanding the biological, behavioral, and environmental determinants of obesity and the impact on child health outcomes. So we are very happy that you join us today. Thank you very much, and we're looking forward to your presentation. The floor is yours.
Thank you very much for inviting me to this excellent webinar. The topic seems to be very salient and easy: risk factor for overweight and obesity among children. We all know you don't need to be a doctor, a medical specialist to know that if you overeat and move too less, you may become a person with obesity. But what is the problem? The situation is much more complicated than we think for the first sight. We have a lot of determinants. Some of them are obvious and some of them maybe not. And today I will try to share with you my experience and evidence-based medicine proofs about determinants of childhood obesity in children. From the basic point of view, we can divide these factors on two groups: non-modifiable and modifiable. Within the first group, we have a huge and still growing impact of genetics, and something what is sometimes missed or put to the same bucket with genetic background is hypothalamic causes. Of course, many of the disorders and diseases of hypothalamic obesity are of the genetic background, but we don't have to forget about disorders and diseases that may be acquired and also maybe a consequences of our medical intervention, like, for example, in children with brain tumors after neurosurgery, after brain trauma, and so on and so on. Let's stop for a while on a genetic background of obesity. Actually, all of the cases of obesity may have some genetic background, but we have to divide it into two groups. The first group, in blue on the slide, is the forms of obesity pretty rare, below 5–6% of all of the cases of obesity, caused by a single mutation or abnormal structure of DNA, causing a very severe form of obesity with early onset. In these cases, the impact of environment is very limited. We also have some space for intervention, especially if we start early. It may be also very good and give us good results. But this is more or less independent on the traditional environmental factors. We can divide it into two groups: monogenic forms of obesity, where obesity is the leading problem. Sometimes we observe additional problems with hyperphagia and some delay of mental development. And in the same group with the similar origin, syndromic forms of obesity, with clear developmental disorder, also congenital malformations or dysmorphic features or inborn organ abnormalities. Both of them are really rare, and we have to focus on a diet intervention as soon as possible. We also have some possibilities of pharmacological interventions in some of them. The other group is polygenic background of obesity. Maybe you are not aware of the fact that scientists have identified more than 600 genes that predispose us to the development of obesity in a favorable environmental impact. And we have no single one protective variant. So we all are some kind predisposed to develop obesity. In this table, you can very clearly see some selected examples of the genes associated with obesity. And as you can see, some of them cause just one form, one type, monogenic obesity, like leptin receptor gene mutation. Some of them may cause syndromic forms of obesity, like Prader-Willi syndrome, Bardet-Biedl syndrome, but some of the genes have more than one role, like, for example, MC4 receptor gene, which may be responsible for monogenic obesity, but it may also play a role in development of this polygenic form obesity. Polygenic form of obesity is a very, very huge group of cases, and I think that most of the cases of obesity in our children is associated with some kind of genetic background, but except those cases with monogenic or syndromic forms of obesity need some additional factor like environmental impact. Very important for the development of obesity, the monogenic forms and also polygenic forms, is this leptin-melanocortin signal pathway. What it really means? It's a structure located in hypothalamus in our brain that is responsible for the sense of satiety and sense of hunger. If something is wrong, the perception of satiety is decreased, and that leads to overeating in very serious form, to hyperphagia. Mutations of one of the genes associated with this pathway may cause very severe forms of obesity. Also, some drugs may affect the function of this hypothalamus regulation, and also brain disorders, brain diseases like brain tumor, surgery, irradiation may also affect this way. So remember that not only genetic problems, but also acquired problems, especially in patients with the history of neurosurgery, irradiation of the central nervous system, may lead to obesity. The other part are modifiable factors. Epigenetics. Every year we see more evidence to the role of epigenetics in the development of obesity, and traditional nutrition, physical activity, psychosocial factors, and environmental factors already mentioned in the lecture of Professor Ahrens. What are epigenetical factors? Epigenetical factors are the factors that affect the expression of genes, but without changing the structure of DNA itself. What is really danger? It may be transferred to the next generation. So the structure of DNA is stable, but the expression of genes can change. And now we know that even without mutation, we can transfer obesity to the next generation from mother to a child. That's why we see the growing problem of childhood obesity, which not only close to the single patient, to our patient, to the teenager or a child, but we have to think a little bit about the past and a little bit about the future in any single case. Recently, we discovered the meaning of the first 1,000 days. I'm really happy to see what Professor Ahrens showed, that the early intervention is the most successful, probably because of this first 2 years of life and the period of the prenatal development during pregnancy really matters. All the things that may happen, the positive things and the negative things within the first 1,000 days are not only responsible for the body weight at the age of 2, but they may affect the future development of the child and even the future generations, so the children of this child. The development of adipose tissue is also divided into phases. The first phase is hyperplasia, so the amount of the fat cell number is developing within this first period. The intervention window of opportunity is within the first 2 years of age. Then we have stabilization, and during the adolescence, we have the second crucial point with hypertrophy and hyperplasia of the fat tissue. And let's go back to the traditional model of obesity. Why children develop obesity? It's easy. He overeats, so he develops obesity. Is it true? If we look into this very simple, we may think that, okay, children are eating too much, so they are getting weight and they are obese. But if we look to the obesity from the opposite side, we will see that it's a disease associated with lack of energy in the cells. We have overload of fat tissue, sometimes overload of the sugar, because if we take the blood sample, we may see in many of our patients elevated blood sugar level. But the real problem of obesity, which is behind the overeating, is lack of energy in the center of the cell. The low availability of the glucose causes overeating. Why the glucose is not transferred into the cells? Because overload of the fat tissue and its activity. Fat tissue is the biggest endocrine and the most active endocrine organ in our body. It may produce, transform a lot of substances, causing in our body the permanent state of inflammation. That causes resistance to insulin, and the process of transfer of the glucose, this metabolic fuel, into the cells is a little bit disturbed. So that's how the vicious circle starts. The people suffering from obesity really cannot snacking despite gaining weight. So we have to look at our patient from the opposite side. Excessive caloric intake is not only the cause of obesity, it's also a consequence of obesity, consequence of the metabolic complications. We have pretty nice proofs published recently. People exposed to the soft drinks, to the oral glucose tolerance test with the huge load of glucose present with excessive snacking several days after. This phenomenon is clearly seen in patients with obesity. It's not so clear in slim patients. But not only the biological reasons are important. Our environment is really danger. We have a lot of opportunities to eat more than we really need. So we have to take into consideration not only the medical reasons, but also the social problems like lower cost of food and drinks, especially those which are low quality, quite successful marketing, especially in social media, and also the technological advances like improved quality of screens, video games, virtual reality, and social media. We are talking about the children, but we as adults, we are working longer. Our children are without any protection, without any contact with parents for long hours during the day. So they take their knowledge and their experience from colleagues and from the internet mainly. We have nice analyses showing that most of our children and adolescents are physically inactive. It sounds really scary, but 81% of adolescents aged 11 to 17 don't have physical activity at least 16 minutes a day. 1 hour is not much. If you take into this the gym classes at school, 81 is physically inactive. The sedentary lifestyle is really dangerous. And what is important and sometimes missed, insufficient sleep. The discoveries of last years show that insufficient or poor quality of sleep may aggravate all these problems associated with inappropriate diet and in physical inactivity. And you know, sometimes I use this when I talk to my patients, because it's really hard to force somebody at the first or the second visit to change the diet or increase physical activity. You understand it's really hard. So sometimes I give one advice: improve your sleep. I try to explain them that using screens 2 hours before getting sleep make their sleep completely insufficient. If you look at your screen 2 hours before you go to sleep, your brain actually perceives it like a sunrise. So for you, it's a morning, a signal to wake up, to increase cortisol level. And if you don't want to change your diet, if you don't want to make your physical activity more, just try to sleep more. Don't forget about drugs and medical conditions. The pharmacotherapy in children is spreading. We use a lot of drugs, neurologists, psychiatrists use a lot of drugs because these problems are getting much more important than it used to be in the past. Most of these drugs are associated with the development of obesity. And if you start the treatment with some drug that may increase the tendency to develop obesity, you should tell about it to your patient. You should inform the patient about the risk and advise what he or she should do to decrease the risk. And if you have choice, choose the drugs that has less impact on obesity. Also, medical condition, actually, We can treat some of them are incurable, but remember that some endocrine and especially hypothalamic problems are also associated with obesity. And I really want to underline that obesity associated with decrease of growth velocity, so your patient is increasing body weight and decreasing height velocity, is always a red flag to diagnose in this patient against endocrine or hypothalamic causes of obesity. The impact of psychological stress is increasing. You know, the life of children and adolescents is not easy nowadays. They present with much more mood disorders like depression and anxiety. The sleep quality is poor, and they have less support from parents and the peers. We still observe the increase of problems, psychological problems and psychiatric disorders in adolescents. That may lead to overeating. It's a trigger for overeating, emotional eating, eating during the night. That causes weight gain. That subsequently is a cause for stigma, bullying, and as a consequence, low physical activity, staying at home, watching screens, and it's a vicious circle of childhood obesity. And environmental factors. Don't forget about environmental factors. If we talk about pollution in the context of childhood diseases, we are always thinking about respiratory tract disorders, skin problems. We all know that the pollution of the air and water is not good for our children. But are you aware of the fact that many of the substances, especially which are used for the production of plastics, may also work as endocrine disruptors, mimicking the action of hormones and changing the metabolism? Some of them put into this table are investigated, and we have hard proofs from evidence-based medicine that they may change our metabolism at the cell level because of mimicking some kind of hormones. Also, a gut microbiome. The microbiome is a very mysterious organ in our body, which may also impact the energy balance, hunger, and appetite. We know that abnormal microbiome is associated with obesity. It is especially important in very early stage of our life. I come back to this 1000 days, because the appropriate microbiota may be protective against obesity. Of course, abnormal microbiome is not the only one cause of obesity, but it may also have some role in the development of the disease in the future. So if we took all this together, the socioeconomic, culture, and pollution, it all may cause huge stress. And what was pretty shown in a presentation of Professor Ahrens, obesity is associated with low level of education of the parents, not just because they have no knowledge. All the surroundings of those people, the way they live, they are used to live, is obesogenic surroundings. So remember that childhood obesity is not very easy disease. It's not only calories issue. It's a complex multifactorial disease, not just an energy imbalance. It results from the interaction of the genetics, early programming, and environmental factors. Remember about this first 1000 days. Don't focus on obese adolescents when the disease is over. Think about the disease before delivery. And also modern lifestyle factors and the current environment are really obesogenic. So we have to educate our patient as much as possible. If we take all this together, we can define obesity as a disease associated with genes, environment, and lifestyle. It's not only the issue of overeating and sedentary lifestyle. Thank you very much.
Thank you very much for this impressive presentation. It's great to see that you have a very similar conclusion as Wolfgang with respect to the time window of opportunity that we should address. So I'm sure we'll come back to that in the discussion. But let's continue first. And last but not least, it's a pleasure to introduce our third speaker, Professor Daniel Weghuber, a distinguished Austrian pediatrician and one of Europe's leading experts in childhood and adolescent obesity. He is the head of the Department of Pediatrics and Adolescent Medicine at the University Hospital of Salzburg and professor at the Paracelsus Medical University there. He also was the past president of the European Childhood Obesity Group, which is the co-organizer or one of the co-organizers of this webinar series. Daniel's work focuses on pediatric obesity, metabolic health, insulin resistance, fatty liver disease, and the prevention of lifestyle-related disorders from an early age. So thank you again for taking the time to join us. We are looking forward to your presentation.
Thank you, Bertold. Dear esteemed colleagues, it's really a privilege to be talking this evening. Now, my task is to address the topic of the management of clinical management of childhood obesity. Let's dive into this right away. Please acknowledge my disclosures. Now, I would like to echo what has been said because this is so important. When does childhood obesity develop? And very clearly, it starts early. It is so important to recognize this, and you can see here the results of 3 different cohorts that were collected in 1985, in 2000, and in 2005 in Germany. And you can easily see that it is between the ages of 4 and 6 that the 97th centile picks up, and this is when the kids who are prone to obesity develop obesity. And the colleagues around Antje Körner clearly show that this is where we need to be looking at. Beyond that age, and this is why I am showing it, the likelihood that obesity persists is really, really high. And this is very much in line with what Małgorzata and also Wolfgang Ahrens showed you. So clearly, if a child is older than the age of 6 and already living with obesity, we need to be seeing this as a chronic relapsing disease with several comorbidities. I just pick the most prominent ones here because in our clinical routine and in our clinical management, we need to focus on early identification. This is clearly metabolic comorbidities, psychological distress we've heard of, and at the end of the day, quality of life. When we see patients and we engage in the journey with them, since this is a chronic disease, it is not a one-stop shop. It is a relationship that we are building. And our graphical artist, Aaron, did this chart for us. And what you can see here is a patient who is desperate, potentially with a lack of intention. So it needs us, and we are the ones in the green suit that supports with good advice to form intent, to prepare and take action. And many patients actually do take off, and their plane flies, and they get into trouble. And this is when relapse happens, and they might crash. So we need to assist them again, be at their side, so that stabilization, maintenance can really happen. I'm using that to illustrate that we are really convinced that this chronic disease needs long-term management. I'd like to introduce you to guidelines presented and published by American colleagues, the American Academy of Pediatrics, that very nicely summarize clinical management as these are the most recent guidelines available, published around 2.5 years ago, together with Canadian guidelines last year. Let's have a look at it. The first recommendation refers to diagnosis and evaluation, and very clearly, we are called to screen children and adolescents aged 2 years and older annually for obesity, and to have a look at comorbidities, to phenotype them, to identify risks, to identify the comorbidities that I've listed, that Małgorzata also nicely summarized for us. They give us a very clear algorithm which of those parameters need to be screened for. First of all, we are using BMI percentiles to identify those living with overweight and obesity. But what you can see here is that the age of 10 is used to discriminate also our actions. And taking a patient history, mental and behavioral health screening to assess potential determinants of health, vital determinants of health, to do a thorough physical examination and diagnostic studies in all of these patients, be they younger than 10 years of age, be they older than 10 years of age, both in overweight and obesity, is the first recommendation. And this might not be known to everyone, but blood pressure is what is really underestimated. We need to screen for hypertension in all age groups across the entire spectrum of BMI. Only in patients who are older than 10 years of age and living with obesity, it is also recommended to do a fasting lipid panel to assess glucose metabolism and to use ALT as a screening surrogate for metabolically associated fatty liver disease. In patients who are living with overweight only, if they are older than 10 years, also a fasting lipid panel is indicated, while glucose metabolism and liver screening is here designed as a may recommendation, so we may do this. Now, this is our clinical approach in terms of comorbidity, but it is very clear that we need to not only identify them, but to also concurrently treat them. And this is particularly not the case in hypertension. There is clear data that children with obesity and arterial hypertension are very likely not to be treated across Europe. In terms of treatment, family-centered and a non-stigmatizing approach is recommended, acknowledging obesity being a chronic relapsing disease, and motivational interviewing as a technique is recommended to engage patients and families. Children aged 6 years and older should be referred to intensive health, behavior, and lifestyle treatment. Should be referred? Well, we need to be realistic. In many places, in most countries across Europe, this is not available. This is not the case. So the recommendation is to deliver the best available intensive treatment to all adolescents with obesity. So take whatever is there and build collaborations. I believe this is kind of a no-brainer, but at the same time, it is a very pragmatic recommendation. Adolescents aged 12 years and older with obesity should be offered weight loss pharmacotherapy. And there is two important things that I would like to underscore. It does not read may be offered, does not say could be offered. It reads should be offered. And the second line is really important also, as an adjunct to health, behavior, and lifestyle treatment. Not as a single shot only, but in combination with health, behavior, lifestyle treatment, which, and we'll come back to that, is not available in many places, and that is an issue we might want to discuss. Finally, adolescents aged 13 years and older with severe obesity should be offered referral for evaluation of metabolic and bariatric surgery. This is an American recommendation and something that we could also discuss at the very end. My personal summary to this is stop watchful waiting. It is not a cosmetic disease. It's not gonna go away. We clearly have the data. Do recognize this as a disease that needs to be treated right away as effectively as possible, particularly acknowledging the fact that early intervention is more effective than later intervention. And if you compare the results of two Cochrane analyses, you can clearly see that intervening before the age of 6 is 7 times more effective as compared to intervening beyond the age of 10. And I do not need to repeat what health, behavior, and lifestyle treatment consists of, but the fact that 26 to 52 contact hours are recommended is problematic when we dive into the topic that I've been given, pharmacotherapy. In particular, when we know that we need to offer this as an adjunct to pharmacotherapy. And although this is not our topic here, we need to acknowledge that bariatric metabolic surgery in adolescents is an effective treatment, and we need to use it in patients that might not have responded to the other treatment modalities. There's several barriers to obesity care in adolescents that I would like to briefly summarize, because they're also really, really important in terms of our management. Individual barriers on the patient side include the lack of knowledge of obesity as a chronic disease. This is really something that we need to share with our families. It is not their individual fault. It is not a lack of will. It is a chronic disease, and we cannot say this often enough, because unrealistic therapeutic targets need to be corrected. These patients were asked in a study called the Action Teen Study, and they here summarized say that they believe they can lose weight and keep it off if they just tried harder, ignoring the pathophysiology again. And they also believe that it is primarily their own responsibility to manage their weight. And this is something that we need to correct when we talk to the family and the support network barriers that also have similar issues as the patient themselves, and they're also facing lack of resources, and we have heard about the socioeconomic dimension of obesity as a disease. There are certainly societal barriers that I will not dive into in more detail, and medical barriers that many of us are really well aware of. Now, when talking about treatment and when talking about weight loss pharmacotherapy, we need to know that this is not only recognized in the American guidelines, but also the most recent guidelines in Canada. And this is why it is worthwhile taking a closer look at obesity medications that have seen approval in Europe. There are two medications, both of them GLP-1 glucagon-like peptide analogs, liraglutide and semaglutide. I will now summarize the relevant data. Fentanyl, the combination of fentanyl and topiramate is only approved in the US, and I will therefore not talk about it now. When we talk about pharmacotherapy, when we talk about nutrient-stimulated hormone treatment, another term, we need to recognize appetite regulation, and there's three pillars. There's the homeostatic, there's the hedonic, and there's the executive function that needs to be seen. And in terms of homeostatics, we eat because we are hungry, and there's a variety of different peptides involved. There's the hedonic pillar, as said, and that is also controlled, and we eat because we decide to eat because it's 6 p.m. and we usually eat there. But the homeostatic pillar is so important because we have learned so much about it. We have now pharmacotherapy. GLP-1 is secreted in the entire body almost, and there's it is secreted in the guts, but there's receptors in the entire body, almost besides the liver. And when we take a look at the first substance, liraglutide, these are the outcome data, the primary outcome data of the so-called SCALE teens trialed, a 56-week RCT. And what you can see here is the intervention group versus the placebo group. Both of them received health behavior lifestyle treatment. And after 56 weeks, there was an estimated treatment difference in terms of change in BMI of 5%. This is against the average health behavior lifestyle treatment effect that is around 1 to 2% at max. Importantly, you can also see once liraglutide was stopped, the treatment effect clearly fades away. Really important is the fact that there is a heterogeneous response that was seen in the trial, and this is very well known for any kind of obesity treatment, be it health behavior lifestyle treatment, be it surgery, and this is also true for pharmacotherapy. We don't really understand it well, and the very likely explanation lies in the polygenic background that leads to obesity that also reflects the heterogeneous response. Now, when looking at the response rates, you can see that around 43% showed a 5% or more reduction, about 1 out of 4 a 10% reduction. So clearly, this is an option for our patients. This was for 12 to 18-year-olds, but more recently, we were also provided with the results of the SCALE Kids study, recruiting patients aged 6 to 12 years old, and that led to the extension of the label from the age of 6 onwards. And I will show you a study patients' characteristics here, what you can see is that they were around 10 years of age, male to female, almost equally distributed, and 70 kilogram was the mean body weight, the mean BMI being 31. And you know that 31 would even be categorized as obesity in the adult age group. So clearly, that was a group of kids with severe obesity, class 1 in 25%, 37% class 2, and class 3, 39%. And the degree of comorbidities was what you would expect in such a group. Here are, again, the results, and they're really interesting because, first of all, the change in BMI was a bit higher. The estimated treatment difference 7.4 as compared to the older groups. So clearly, again, echoing what we have heard earlier, that if you intervene earlier, the likelihood for an even larger effect is also seen here. But what is even more important is a message that we need to know. When you look at the body weight, change in percent body weight here, you can see that at baseline, intervention group was very, very much same as at the end of the treatment phase. So it basically did not change, while the placebo group had a constant increase. So clearly, the reduction in BMI was driven by the increase in height by their growth. And this is also something that we need to talk about when talking to parents who ask us, is this really something that is effective in that age group, and what can we expect? We can expect a reduction in BMI and a stable weight. Now, looking at semaglutide, another GLP-1 that was tested in the so-called STEP-Teens trial, very similar design, around 200 kids randomized in a 2-to-1 fashion to either semaglutide 2.4 milligram once weekly or placebo, all of them receiving health and nutrition and physical activity counseling. And this is, again, the demographics. And again, what I would like to emphasize here is the mean body weight and the mean BMI of 108 kilogram and 37 kg per square meter. The adult patients in the adult trial were only 105 kilograms, so clearly a high obesity rate and severe obesity with very, very typical comorbidities present in that group. Here are the results, and you can see the relative change in BMI over time, and the estimated treatment difference here was minus 17%. So we come from 5% in the 12 to 18-year-olds with liraglutide, 7.4 liraglutide in the 6 to 12-year-olds, to around 17% BMI reduction, which is substantial in that study. In terms of categorical weight loss, more than 70% achieved 5% or more, and more than 1 out of 3 had a reduction of 20% or more BMI. This translated into improvement of practically all metabolic parameters, blood parameters, even though the mean HbA1c within the normal range at baseline, there was a significant improvement. The same was true for ALT, which was also within the normal range. There was an improvement. There was an improvement in lipid levels, significant improvement only in HDL-C. It was not significantly. And this is important. there was an improvement in obesity-related quality of life. And this improvement was driven by the so-called physical comfort score. It was a questionnaire. It makes sense because the average reduction in waist circumference was 12 centimeters. So this is really something that the kids acknowledged, recognized. They had to buy new trousers. I really recall some kids who would come in with a smile in their face, protesting that they had to buy new trousers again. So this is driving the physical comfort score, and at the end of the day, the total score of obesity-related quality of life. In terms of distribution of BMI categories at baseline and week 68, the three colors represent obesity stage 1, 2, and 3. There was not much change in the placebo arm at week 68. And when we look at the semaglutide group, you can see that almost 45% were now below the threshold of overweight and obesity, and would be actually in a state of clinical remission if you want to. Looking at adverse events by organ system, organ class, very clearly this is what we expected. Gastrointestinal disorders are at the very top. This is very, very frequent. We'll come back to that. Skin and subcutaneous disorders, tissue disorders are also frequent, but are not a major issue in clinical practice. Hepatobiliary disorders, mainly cholelithiasis, but also cholecystitis in 2 patients were seen. And this is also something that you need to be in the lookout in your patients, particularly in those who show a substantial loss of weight and reduction in BMI. Psychiatric disorders, depression, suicidal ideation, or suicidality was less common in the semaglutide group and more common in the placebo group. Again, this is something we can discuss. I mentioned it already because I believe it is so important. There is a clear recommendation that health behavior lifestyle treatment needs to be offered in combination. On the other hand, it is in many regions not really available. At least the availability of 26 to 52 contact hours is unrealistic for many of us. So what I will show you now are own data from Salzburg in a very, very small sample, but I use it to illustrate where we have gaps and where we need to do research in the future. We divided a cohort of patients receiving liraglutide who came in to our outpatient obesity clinic one after the other, no randomization, and we offered them health behavior lifestyle treatment in a group setting that was not obesity medication specific. We call it high frequency HBLT here. And if they were not if they did not want to go into the group setting, we offered them, and this is what we still do, obesity medication specific HBLT in less frequency, only around 10 contact hours across a year. And what you can see here is the mean percent change again. And at least what we can see is that the 2 groups were not really much difference. There was even a trend that the OM specific group had a larger decrease in BMI, but this was only a small group. Those who did not receive any support in terms of HbA1c had a very low reduction. So this leads me to a very important study that is currently ongoing in the US, trying to address the question how much HbA1c is really needed alongside obesity medication. It's a so-called lifestyle counseling and medication for adolescent weight management QUEST trial. And we did not really share our results with Aaron Kelly and his team, but they designed this two-arm RCT, basically separating and randomizing the patients into two groups that were very similar to what I've just shown you from my own Salzburg group. Now, before coming to an end, I think it is important in terms of what we do clinically that we need to recognize that there is different phases when we treat patients with obesity medications. There's the preparation and initiation phase, there is the weight loss phase, there is the maintenance phase, and discontinuation is to be expected and needs to be addressed. And there's different things that we need to recognize and address in these different phases. And these different aspects are listed here: nutritional and lifestyle assessment and physical assessment at baseline. We need to counsel obesity medication specifically. We need to manage gastrointestinal side effects effectively. Nutritional counseling is helpful for that. We need to monitor the effect continuously. We need to promote physical activity, and this is something that we are currently developing into what we call medical nutrition toolbox that we can offer both to you as pediatricians, and that you will then be able to use when talking to their families. So this is a heads up. This is something that will be presented this year. This is to ensure adequate energy and nutrient intake to support the management of acute adverse events in the long term to improve adherence to treatment. Now, health systems response to childhood obesity is a crucial issue. How are we to use these medications, our treatment modalities in our health systems? We need to improve our health systems in this regard. And just to give you an example, this is the Austrian approach that we are currently developing. What you can see in the middle is the primary care physician. This is the family physician caring for the child, but he needs or she needs partners in the disciplinary childhood obesity centers that we are setting up across the countries that are collaborating with the primary care physicians. There is rehab centers in Austria, obesity rehab centers that have their effectiveness, but that effectiveness is limited, so it needs to be incorporated into the entire structure, and surgery is also part of this. But the main point is a chronic disease needs chronic disease management over time. And we also need to identify new strategies, digital tools. And one of them I would like to introduce you to here, an app called Vera that is a combination of a scale and an app. Kids are basically or step on a scale that does not show them the actual numbers, but it shows them the development of the BMI presented as standard deviations, and thus just a line across over time, and give them continuous feedback. And this has been shown to be effective not only after 1 year, but also after 3 years, but by the Swedish group. We can discuss it, but I'd like to conclude at this point. Lifestyle interventions are the cornerstone of treatment, but have their limitations. Obesity medications beneficially alter the underlying pathophysiology, essentially to changing behaviors. There's two approved anti-obesity medications, liraglutide and semaglutide in Europe, but we need to include them into our health systems response. Obesity medication focused patient-centered interventions are important, but we need to really see how to deliver them, whatever is necessary to better to improve adherence and safety. So having said that, I would like to thank you very much for your attention and also draw your attention to the European Childhood Obesity Group annual meeting in Salzburg, where we will be diving into these details in much more depth. Thank you so much.
Thank you very much, Daniel, for this great presentation, which addressed a lot of issues that are very relevant for pediatric care. So before handing over back to Arthur to moderate the discussion, I have one more request to you, that is to ask you for a short poll, which should appear on your screen now. And I would like you to take a short moment to answer these poll questions, which are in your clinical practice. Which area represents the greatest current challenge in managing children and adolescents with obesity? Early identification and accurate classification, addressing modifiable risk factors within families, access to multidisciplinary obesity services, or long-term follow-up and continuity of care. So please give your feedback, which is your greatest challenges. So it seems very clear. Access to multidisciplinary obesity services is the clear leader. But there's other challenges as well. Continuity of care, addressing modifiable risk factors within families. So over to you, Arthur. We have some questions and we have a few minutes left.
Once again, thank you all speakers for excellent presentation. And we have some questions of the questions and answer box. The first, referral to bariatric surgery should be done after pharmacologic treatment. I think this is the question for Daniel.
Very clearly, our world is changing and we have new options, and I would fully agree. There's more than 50 molecules that are in the pipeline. So acknowledging this, we are a bit more hesitant in offering a treatment that is irreversible. On the other hand, there's patients who we have offered pharmacotherapy, but who would still have several comorbidities, who have a high likelihood, a high risk of developing cardiovascular disease early. And we need to take an educated guess into in these patients what the correct risk balance is. So weighing the balance is important here, but bariatric surgery is still an option in some of these patients.
Thank you, Daniel. And the next is from Dr. Christine Mangendi. I think we should more focus on promotion of healthy behaviors and prevention, also societal marketing, microbiome any antibiotic treatment. So I think this is the question for Małgorzata.
Thank you for this question. I believe you have fully understood what I wanted to tell you. As physicians, we are very familiar with treatment. We like disease, we like drugs, we know how to treat. But in the case of obesity, you have to go out of the box. The strength of the media, advertisement, and industry is really, really big. Let me give you an example. The taxes for beverages in Poland, we have the same tax for the water in bottles and for alcoholic beverages. The sweet beverages like juices, juice-like beverages are with the lower tax. So it's crazy, but it is our reality. And if you go into the details, we are actually on a very, very weak position as a people who are aware of the fact how many traps are in front of the people, in front of our patients, in front of our families. And what is really important to think what we do. If you prescribe antibiotic, think a little bit ahead, not only about the disease. If you advise to use prebiotic, think about the consequences. If you give a drug that may increase appetite, for example, for the child with epilepsy, think about the consequences. Of course, you cannot avoid this medical treatment because you are a doctor, you have to do it. But think about the consequences which are a part of the direct action of what you do, and inform your patient. Inform your patient what can happen. So that's my opinion.
Thank you very much. And may I ask Daniel, what you have showed us the structure of the healthcare system for childhood obesity children in Austria. What is in your opinion, the role of the primary care pediatrician in this system? Our next webinar will be topic of this, and what is your opinion? What should or what kind of role can play primary care pediatrician?
A central role, and this is why I presented the slide. The primary care physicians, pediatricians, they know the family. They are perfectly positioned to take care of the child over a long period of time. But very clearly, given the time restraints, we need to develop a system where primary care pediatricians and physicians have partners that offer more specialized care, that start, for example, obesity medication, that identify patients or help in the identification of patients with monogenic disease, that take care of those who are living with obesity at the highest degree of burden. And this is why we are setting up pediatric obesity centers across Austria for those with obesity and comorbidities. This is why we are setting up a health behavior lifestyle treatment that is low barrier, that has low barriers of access for those with overweight. And we need to work together very, very closely. This is maybe something that will only happen in the future, but if we do not work to develop the system, it will not be established.
I showed that Wolfgang would like to answer. Please unmute.
Yeah, thank you. I had to unmute my microphone. I took the freedom to answer 3 of the questions in writing, but in essence, the message that I'd like to convey is always the same and links to what Małgorzata has rightly explained. I don't like the term lifestyle, although I use it several times, but I try to get rid of this word because the term lifestyle, when it relates to health behaviors, gives the impression that it's free choice, which is not the case in children. Let me take the example of physical activity. The better we measure physical activity using accelerometry, the stronger the health effects, the beneficial health effects are that we see. So it's one important factor. Now, if we consider the environment, then we see that even parents who see this and who would like to promote physical activity of their children don't dare to let their children play outside. Why? Because the environment is not safe, or the environment, there is no green environment where they can freely and safely play. So not playing outside is not the free choice of the children. It's determined by the environmental conditions. And for that reason, and I think that's what we have learned, addressing behaviors doesn't work. That's what we have learned. And maybe this is one of the reasons, because we in the past did not consider the environmental determinants, the environmental drivers that shape behaviors. I can give examples for nutrition. I can give examples for mental health and mental well-being, especially social media are bad for this. So I'd like to recommend get rid of the word lifestyle when we are talking about health-related behaviors that need to be changed. And when we want to change these behaviors, think of the driving forces of the upstream factors. That's, for me, the important message for prevention.
We have very interesting and very important question from Laura Reali. When and where a pediatrician can achieve the best results in the counteracting obesity, and which tools are the most efficient? I think this is the question for all our speakers. Daniel?
The question is how we can identify what best suits an individual child. And a child with monogenic obesity age 3 is completely different to a 12-year-old with obesity stage 1 and a 17-year-old with severe obesity. So in primary care, very clearly, we need to start with the simple, low-hanging fruits when we address health-related behavior. And one aspect is clearly drink water. Drink water. Get rid of everything else. And then it is simple messages that need to be conveyed very consequently when developing a relationship with the patients. While in other patients, we might need to address other issues like sleep, like social media, like physical activity. Part of the answer.
Thank you. Maybe Małgorzata?
Yeah, we have really nice results of randomized trials focused on the intervention, and most of them show that the impact is really poor. But, we have to think about the quality of these papers, of this research, and about the endpoint. Usually, they are addressed to decrease of BMI because something has to be measured. And if we define treatment of obesity like decreasing BMI, we are completely on the false pathway. But the treatment of obesity is not focused in the clinical setting on the BMI decrease. It may be the endpoint for the research, but not for the clinical set point if you want to be successful. Change of the behavior is the goal. So I totally agree with what Professor Weghuber said, but I would strongly underline the personalization of the intervention. At first, you have to do an individual research for every single case and every single family. You have to address the intervention into the particular family. For example, if the problem is low quality of food, you have to think what is the source of it. Is it a financial problem or lack of education? If the physical activity is low, why? Is it because they are not used to be active, or maybe they live in a place where this physical activity is completely impossible to be done, or maybe a child suffers from additional diseases like orthopedic problems or asthma, and it's difficult for them to meet the criteria of WHO. So in a clinical setting, we have to think a little bit different than in research setting. That's my opinion.
And one question more for Daniel about who should prescribe the anti-obesity drugs, primary care pediatrician or subspecialists, or after the consultation, primary care with specialists?
This is an ongoing discussions across Europe, and I think at the time being, a pragmatic approach makes sense. We are still in the learning curve, how to handle treatment. And this is why it was decided in Austria that the initial prescription has to be handled by pediatric obesity centers that are available across Austria. But obviously, it is not possible to treat all of the families here. So this is why we hand over treatment to well-trained primary care physicians and collaborate with them. So this is where we are at the time being, and under these conditions, there is reimbursement for these medication, as long as a clear assessment is given and evaluation of the process is given. But we will be developing this in the next years.
So I think that we are going to the closing remarks. We have a lot of questions, but time is rising. Thank you very much, Professor Kolecko, for chairing this webinar, and thank you all our speakers for their excellent presentation and valuable insight. Childhood obesity is a complex and urgent challenge, and today's discussion has highlighted the importance of continued collaboration across healthcare settings. We are very grateful to all participants to joining us and for your active engagement throughout the webinar. And this session was the first of the three-part obesity webinar series, and we warmly invite you for the next our webinars. The second webinar will be held on the 18th June, also at 5 p.m., and on the topic, the role of primary healthcare physician in the management of childhood obesity. The third will be held on the 24th September this year, also at 5, on the topic practical management of childhood obesity, lifestyle, nutrition, and treatment tools. Together, this session are designed to create a practical clinical pathway from understanding childhood obesity and public health issue to implementing effective management strategies in daily practice. We also look forward to seeing you at the European Academy of Pediatrics flagship event in this year, the annual Pediatrics Forum and Master Course, which will be held next week in Tbilisi, and CPAS Congress. This is Congress European Pediatric Academic Societies, which will be held in October this year in Lyon. You can see the details on the screen. We look forward to continue this important conversation together. Thank you once again, and we wish you a wonderful evening and goodbye. Thank you once again, all speakers. Thank you, Wolfgang. Thank you, Daniel. Thank you, Małgosia. And thank you, Bertolt. And especially thank you, EAP Secretariat, for organizing this webinar. Thank you, all participants, for being today with us. And we invite you to the next webinars in June and September. Thank you very much. See you soon.